This morning, I'm actually going to be double teaming with Yvonne. Autoimmune diseases are the most classical mixed pain states. And actually, I'm going to sort of really focus on the peripheral component. And then Yvonne, I'm going to hopefully set up Yvonne to talk about the central component, because both are really quite important in managing our patients. So these are my disclosures, none of them which are directly relevant to the content of my talk. So who are my patients? So in Scotland, I'm a rheumatologist, and we have a great bias towards managing patients with inflammation in their system. And this includes patients with rheumatoid arthritis, lupus, axial spondyloarthritis, psoriatic arthritis, and vasculitis. And in essence, all these different disorders have different dysfunctional immune pathways at play, leading to very different phenotypes. However, if I was to ask my various patient populations what their priorities are, invariably pain ranks number one. It's the biggest deal for our patients. It has been a privilege being a rheumatologist over the last 15 to 20 years, because there has been a transformation in how we manage pain and manage the underpinning disease. And I'm going to focus this talk, and I think Yvonne's going to do the same, around rheumatoid arthritis as a prototype for autoimmune disease. And I think many of the concepts that we'll be discussing are really transferable across the spectrum of autoimmune disease. I'm going to try and exemplify the transformation that I've observed over the years, a couple of cases. The first case is genuinely the first patient I remember managing with rheumatoid arthritis many years ago when I was a resident. At that time, we had a full ward of patients with rheumatoid arthritis at any one time. Now, I don't have a ward anymore, and that sort of speaks to the change that we observed. So this patient, 49-year-old ex-nurse, was referred in from clinic. She had an established diagnosis of rheumatoid arthritis for 5 years, and she'd gone to her clinic to see her consultant, complaining of crippling pain and progressive immobility. So she was referred, as many people were, for an inpatient assessment and sort out. Her past medical history, despite her relatively tender age, included ischemic heart disease, and we now know that systemic inflammation not just targets the joint, it can affect every system, including the blood vessels, and premature vascular diseases, or certainly was rather prevalent in those days. The inflammation can affect other organs as well, including the lungs, and she had some interstitial lung disease. She was chronically constipated, and I'm sure everyone can guess in this room after the last couple of days of talks why she was constipated, and I won't even go there. She had a right total hip replacement. This is from really poorly controlled aggressive rheumatoid arthritis causing damage. And she had diabetes. Again, that's related to a drug toxicity, which I'll go on to speak about. Socially, unfortunately, medically retired. The impact of the disease was greater than just to her. It affected her whole family, leading to divorce. Teenage daughter was the main carer. So back then, rheumatologists adopted what we call the pyramidal approach. We did have medications there, such as methotrexate and sulfasalazine, which could get at the abnormalities in the immune system. But we were so scared of these drugs then that we'd only really used them when we were desperate, many years down the track after diagnosis. Instead, we would focus, rather ironically, on medications that we now know are 10 times more toxic than these DMARDs. So this patient, she's been stuck on morphine for many years. in my world, if there's anything worse than opioids, it's steroids. And steroids are associated with a whole host of adversities, including diabetes, hypertension, osteoporosis, severe infections, the list goes on. Even non-steroidal anti-inflammatories, which have been around for a while now, used chronically, they're increasingly being shown to damage the blood vessels and are at higher associations with ischemic heart disease and cerebrovascular disease now. So we've been basically poisoning her for a few years. A clinical examination, she had knees which looked a bit like this, which evidence swelling, which has probably got an inflammatory component to it, but also a lot of damage as well. And certainly her feet, as you see, are clearly very deformed, and this is all damage, accrued damage over many years of having this terrible disorder. So what did we do for her while she was in the ward? Well, I, as the medic, did very little, to be honest. In those days, I injected a couple of joints, which provided some short-term relief. The real good work was done by our physical therapy colleagues, getting them mobilizing, the occupational therapist going to her home and fitting in shower aids. We had belatedly given her methotrexate. It clearly wasn't working. And then we switched to gold injections. Do you remember gold injections, Dan? Or is this just a Scottish thing? I still laugh at the fact that I used to use... So it wasn't just Scottish. So that's how desperate we were. And there is some evidence behind gold injections, but it's not great. But we reached for gold when we were desperate. And that's what we did in this patient back then. And ultimately, she needed her joints replaced, and we got orthopedic surgery involved, and she was waitlisted for knee replacement. But overall, I mean, all these factors together, she had a very poor prognosis. I don't know what happened to her, but my suspicion is that she would have an 80% risk of mortality within 10 years. So as I've shown, rheumatoid arthritis is more than just the joints. This inflammation gets everywhere, including the brain. But the hallmark feature is pain, and the hallmark feature is inflammation targeting the joints. You can see this inflammation in this picture here, red, hot, swollen joints. You're not surprised that these are very painful for the patient. So what's going on inside the joint? Well, the normal joint incorporates a natural shock absorber, which is basically the synovial fluid sac. And it's here that the immune system and the inflammation is targeting, causing that red, hot swelling that you observed. But we need inflammation in our bodies. It's there for a reason, of course. We need the immune system to protect us from infections and other things. So very briefly, when our normal immune systems, how we deal with infections, is we have the innate immune system, which involves cells such as neutrophils and macrophages, which help control the infection in the short term. And then we have the adaptive immune system, which incorporates B cells and T cells, which help eradicate the infection, and also, very importantly, produce antibodies to help protect us from infections down the track. Now, it's these antibodies which can go wrong sometimes, and in rheumatoid arthritis, what we believe is the culprit is in those people who are genetically predisposed. An environmental insult comes along. It might be a microbe, it might be a period of stress, and this triggers the immune system to generate aberrant antibodies which go on to target things they shouldn't be targeting, including the cartilage in the joints. And over time, this inflammation ramps up to cause and generate this terrible pain. And over the last 10 or 15 years, since that patient, there's been amazing progress of very clever biologists really parsing out what is going wrong in the immune system, what are the pathways, in particular aberrant cytokines such as TNF-alpha, IL-6 have been identified, and from that, new drugs have been developed. So it's these cytokines alongside the cells and prostaglandins which are in that terrible milieu in the joint, which goes on to sort of stimulate the the nociceptive nerves, the primary afferent nerves, which then go to the spinal cord and cause sensitization there and ultimately to the brain. And you heard yesterday from Rick of the different modalities that we can use to evaluate pain. And one of them, quantitative sensory testing, you can see here if you squeeze those joints that patients have poor pain thresholds. And Yvonne's shown that those poor pain thresholds relate to measures of inflammation. So this is good evidence of peripheral sensitization. But also if you squeeze the joints and you stick the patients in an MRI scanner at the same time, you'll see that the regions of the brain which are culprits in pain also light up. So rheumatoid can cause acute inflammatory pain, but over time it needles away at the joint, causing destruction and leads to nasty x-rays like that, I'm afraid. And clearly that's another mechanistic route of peripheral pain generation. The mechanoreceptors there clearly going to be very unhappy, leading to pain and ultimate joint replacement. So I alluded to the fact that there's been a change over the last 10 or 15 years, and probably the first breakthrough was for us to realize that we should no longer be scared of these DMARD therapies, which soften the immune system response. This is nice data from Europe, which shows that if you get in early and you diagnose patients within 12 weeks and you start treatment at the beginning rather than at the end, you can completely transform the number of erosions. That's a good measure of joint damage in the rheumatoid arthritis joint. The number of joint erosions is reduced significantly just by getting in there with an early diagnosis. And I appreciate in this audience there's a lot of you will see many patients coming to you with joint pains, and you might be the first contact. And you might be thinking, hearing this talk, well, how can I pick out these patients who have the more inflammatory arthritis so that I can get them referred on to rheumatologists sooner rather than later to improve their longer-term outcomes? And I'll very quickly go through a few pointers to help basically distinguish inflammatory peripheral pain from the more mechanical pain, which is far more prevalent, whether it's osteoarthritic in origin or centralized in origin. So inflammatory pain tends to be worse in rest and better on movement. Patients report substantial early morning stiffness relative to mechanical pain. But the key thing for me is having a good look at the joints and looking for that swelling and making sure that that swelling isn't hard swelling, because hard swelling, and many of you may have looked at your grandparents' joints recently, I bet half of them will be quite hard and knobbly joints. It'll come to us all, I'm afraid. But what we're interested in here in inflammatory arthritis is the soft, spongy swelling, which is pretty pathognomonic of inflammatory arthritis. And us rheumatologists now have fancy tools to help us quantify and diagnose this more. We have ultrasound, which shows there's fire in the joint, which is the inflammation. Some of us used to stick needles into the joint and then take out the fluid, and you can see that the fluid in our joints should really look like a gin color, whereas it's an inflammatory joint, it's clearly angrier. And these days we've remarkable progress in making early diagnosis because we can measure some of these aberrant antibodies I was telling you about. And in particular, there's an antibody called anti-CCP antibody, which I call the super rheumatoid factor, because this is highly specific, unlike rheumatoid factor. So 90% specific, and it's also prognostic as well. If you have high CCP, you're likely to have poorer outcomes. And now in Scotland, and I'm sure in the US as well, this is widely available to all primary care practitioners. And as soon as they get a patient who they wonder has rheumatoid and they do this blood test, we will see that patient within 6 weeks so that we can institute treatment. So I'm glad to say I can't remember the last time I prescribed gold. There's far better uses for gold. And again, because of the amazing insights of a number of clever biologists over the last years, We've now mapped out what's going wrong and now developed appropriate treatments. And essentially, we can target so many different elements of the immune system now with these biological drugs. So we can manipulate the T cells that go wrong. We can manipulate the B cells that produce the aberrant antibodies. We can mop up the excessive levels of cytokines. It's been an amazing time to be a rheumatologist. And these biologics have been, most importantly, amazing for our patients. And you can see here what they do to pain. But you can also see that the pain doesn't go to zero. And I think that's an important point as we move forward. Many people ask me, is there a drug that's better for pain relief in the context of these fancier biologics? The truth of the matter is they're all much the same. There's certainly different individuals will respond better to certain drugs. Rheumatoid is a heterogeneous disease. What the abnormal pathways are in one patient will be different to another patient. But on a population level, these drugs are pretty equivalent. These drugs are also very expensive. So this is data from 2012. I'll remind you that rheumatoid arthritis isn't as common as heart disease and diabetes, but it's the drugs at the top 3 drugs in terms of income generation for the pharmaceutical industry are 3 biologics used for rheumatoid arthritis. So these drugs are far more expensive than gold, and they don't cure. Patients are on these drugs pretty much forever, so this brings in a lot of income. And an important message to take away is that while these drugs have been transformative, it doesn't mean that some of the older drugs like methotrexate and sulfasalazine aren't just as good if used early and aggressively in combination. And in Europe, we've done lots of trials to just evidence that. So I know practice varies across the world, but certainly in Europe, we would still wish to use methotrexate, sulfasalazine first line, because if you look back at the cost of these other drugs, I mean, what else? I mean, how many physical therapists, how many occupational therapists, how many psychologists could we support our patients with if we could even have a fraction of that money? Something that we're very proud of in Scotland and doing trials around of improving outcomes in rheumatoid hasn't just been around early diagnosis, but also intensive follow-up. So when we see a patient and we diagnose a patient, we monitor them really closely, sometimes every couple of weeks or so. And every time we see the patient, we ask ourselves the question, has the pain improved? Has the inflammation disappeared? And if not, we ramp up the treatment. We're very aggressive. And by doing that, particularly in the early stages, we can improve outcomes, particularly pain. So that first patient I referred you to, inevitably it'd have a lot of joint replacements. I can't remember the last time I've had to refer a patient for a joint replacement, which is a great success. Patients still get damage to their joints despite these more aggressive strategies. But the number of erosions that people get in their joints is really small comparatively. And actually the observational data, when you relate these X-ray changes to pain, they don't show an association. So I suspect that this current level of damage, that's probably not enough to be contributing greatly to the overall pain. And despite these fancy therapies, I really want to emphasize that the MDT was a cornerstone back then and remains the cornerstone now. It's just that we're more ambitious. And rather than trying to encourage our patients to get out of bed to the toilet, we're now encouraging our patients to stay and work and to live a completely normal life with great travels around the world. That's our aims, and that's what we're trying to achieve. And together with the MDT, we have been able to, combining the pharmacological approaches, to reduce work disability. So it's all been a great success story. And I really hope that in the years to come, when I'm teaching medical students about rheumatoid arthritis, and I'm trying to find patients with rheumatoid arthritis in the wards to do some bedside teaching, that we will not see hands like this anymore. And if we do see hands like this, it's a failure of the rheumatologist of not making a diagnosis early enough and not treating aggressively enough. So let's speak about my most recent rheumatoid arthritis patient now then. So this is a 59-year-old businesswoman, again, a 5-year history of rheumatoid arthritis. Her presenting complaint was pain, just like that patient 15 years ago, and also fatigue and major concerns about whether she can continue on her employment. Unlike the previous lady, she had no joint replacements, she had no cardiovascular disease. By better treating the inflammation, we're stopping all these other complications of this condition as well. But the brain-related complications still remain. Depression remains highly prevalent. Anxiety is very high. And she did struggle with depression. But she remained in full-time employment. She was single. And it was those valued active activities, the hobbies, which were still constrained. So our treatment did follow this treat-to-target approach of diagnosing early, monitoring very closely, started the methotrexate, combination treatments, and then finally getting onto biologics. And as a result, that's what her hands look like. So very different. There's no swelling there, there's no hot, boggy joints. So why then is she reporting significant pain? Pain that is enough for her to reconsider her career and stop her doing the hobbies that enthuse her so much. And she's not alone. So this is data from our UK biologics registry, where we're very careful to monitor every patient who's been started on one of these expensive drugs. And it hones in on patients who have apparently completely responded to these drugs. They have no swollen joints. They have completely normal inflammation in their blood. And this is data asking on that population level of thousands of patients what their pain levels are. And it's the SF36 bodily pain score. And it basically shows that 50% of patients have a score of less than 40. And 40 is a greater than 1 standard deviation level of pain compared to the general population. So there's clearly other mechanisms at play here. It's not just about inflammation. And despite us making these great strides, there's a lot more that we should be doing for our patients. Me and Yvonne and others all sort of feel that there are central pain pathways to explain this disconnect. And I'm very pleased to hand over to Yvonne to talk a bit more about those more central aspects. Thank you very much.